Yes, thank you. This is exciting. Welcome, everyone.
All right, well, it's 1 o'clock, so I guess we'll go ahead and get started. So yes, welcome everyone to our first, actually, CFHA webinar of 2020. I wanted to say 2019, but welcome everyone. I'm Liana Edwards. I'm the admin assistant here at CFHA on staff, and we're really excited for today. So I just had one announcement, so to speak. So the call for proposals for our 2020 conference in Philadelphia is now open. That will close March 15th. So if you have something you'd like to present on and you want to get a team together, you can head over to integratedcareconference.com and submit a proposal. So with that, I will hand it off to Clarissa to introduce our wonderful speaker today.
Hello, everyone. Bienvenidos a todos. We're very excited to have you here, and thank you for making the time in your very busy day to join us. I'm very, very excited to present our speaker. First, a little bit on me. My name is Clarissa Aguilar. I am the 2019-2020 co-chair for the Primary Care Behavioral Health Special Interest Group, and I myself am a bicultural Latina, and I'm committed to decreasing health disparities through the PCBH model. And for this reason, I'm very excited to have our wonderful expert speaker, Florencia Lebensohn-Chialvo. She's the assistant professor in the Department of Counseling and Marital and Family Therapy at the University of San Diego. She received her doctorate in clinical psychology from the University of Arizona and completed her pre-doctoral internship in clinical child psychology at UCLA Neuropsychiatric Institute. She holds a master's degree in psychology and a bachelor's degree in history and Latin American studies from the University of Arizona. Her research and scholarly work seeks to identify effective strategies for training behavioral health clinicians in evidence-based practices. We are very excited to have her. She's currently a product director on the HRSA Behavioral Health Workforce Education and Training Grant, and she is focused on increasing the number of effective, culturally competent, and diverse behavioral health providers committed to serving vulnerable populations. I mean, does that not fit exactly with what we want to do today? I love it. She's a native of Argentina and greatly enjoys providing Spanish language supervision and training. So without further ado, here she is to talk about our very complex but wonderful topic of serving our Latinx community.
Gracias, Clarissa. Thank you so much for that lovely introduction. Thank you all for taking time on a Friday to come and listen to this. That's real dedication. To start off, I so appreciate Clarissa and Norma referring to me as an expert. I don't particularly self-identify that way, but this is a topic that I'm quite passionate about, but I really do consider myself as someone who's learning right beside all of you on this topic, but happy to share what I know, kind of what the state of the science is thus far, so kind of what we know and what we don't know yet, and then tackling any questions that you might have that may or may not have answers yet. So looking forward to some rich discussion. But to start us off, I thought, one of the things that I'm always impressed with whenever talking about Latinos, whether they're Latinos that live internationally, like the diaspora and where we all are, or thinking about the community here in the United States, is that, we're basically impossible to describe. So I thought it might be helpful to just try and describe a little bit of the characteristics that make up our Latinx community here in the United States, to just set going to give us a foundation to start our discussion from. Oopsie daisies, now I'm having, there we go. So, ¿quiénes somos? Who are we? Estimates have us at about 58 to 60 million Latinos that currently live in the United States. So we are an incredibly large community. And we have lots of different voices that make up that community here in the United States. One of the things that is so makes up such an important part of our identities as Latinos is whether or not, what is our nativity status? What is our citizenship? How do we identify? Here in the United States, recent estimates have it at about 65% of Latinos in the United States are native born. So that means they were born here in the United States, while about 35% or a third, a little more than a third, are foreign born. Of the foreign born, we have about 12-ish% that are now naturalized citizens. So that means that they've been able to go through the process and achieve citizenship in the United States. Why this is important and why I thought it would be something to discuss today is that, oftentimes when we're talking about our Latino communities in families, we will have, it's definitely not a homogeneous characteristic of a family. We can have families where there are some that are native born, some that are foreign born, some that have papers, others that don't, some that are have been naturalized and are now citizens, and some that are still in the process. So it's a pretty critical characteristic and challenge that our Latino communities struggle with every day. And as we'll kind of talk about later, nativity status, so whether you were born in the United States or whether you were born in outside of the United States, really does have significant impact on your utilization of healthcare. And so we'll talk about that a little bit later. Okay. ¿Por qué estamos acá? And I say acá because I'm, de Argentina, and we say things a little bit differently. But why are we here? And it's important to recognize people, Latinos have gotten to the United States in different sorts of ways. Obviously, those are those that were born here in the United States. But for those of us that have immigrated into the United States, there's different ways that we have gotten here and different reasons that we left our countries of origin. And so it could be a whole history lesson on this, but some of our Latinos arrived as part of state-sponsored labor programs, whether it was trying to bring Mexican immigrants into the United States or Puerto Rican workers to the United States with Operation Bootstrap. But that has definitely shaped the history and the culture of those groups. Some have come as refugees or asylees, and we see that a lot in terms of our Cuban and Cuban American communities, and those that are here after coming from Central American countries, and also some South American countries as well. So issues of civil war are critical in their immigration stories. Severe unemployment and underemployment, political and economic unrest are some of the reasons that they have found the need to leave their country of origin and come to the United States. Some are born in US protectorates, and Puerto Rico is a wonderful example of this. And they have chosen to, for many reasons, and we see this right now with all the natural disasters that are hitting, unfortunately, Puerto Rico in the recent months and years, kind of a mass exodus of their population and coming to mainland US because they have the right to do so. And then we have others that are here undocumented. And obviously that immigration story is critical to their identity and then how they navigate the system here. ¿De dónde venimos? Where do we come from? That's just such a complicated question. But obviously, we have a significant portion of our Latino community that either came from Mexico or their families came from Mexico, but significant portions of our Latinos are Puerto Rican, Cuban, from El Salvador, from the Dominican Republic, Guatemala, Colombia, and then these little ones on the side. There's about 1 million or less of Latinos that are from those countries of origin. So why is this important? You know, for many of us, our countries of origin impact a lot of our beliefs that we hold, and mental health and physical health are no exceptions. Where our countries of origin greatly impact our diet, our relationship with food, for sure. Our beliefs about physical activity, exercise, health in general. Our countries of origin impact how we think about family, how we think about what our roles and responsibilities are. And with such a diverse set of countries that are represented, that you're not going to necessarily have, you know, one set of beliefs and or cultures and traditions, but really it's going to be quite varied. This also impacts, and we'll talk about this in a little bit, in terms of you know, how much social support these communities have. You know, and how many community resources are really tailored to them or for them, given their country of origin, and what they might be able to tap into or identify as something that is available to them. So, ¿dónde vivimos? I feel like this is a really important, critical question as well. So, where do we live? We have some what we call traditional destination areas. So different counties in California, in Texas, in Florida, in New York, New Jersey. These are areas where we know that there are large communities of Latinos that then draw, you know, more Latinos to go there, in large part because of those questions of social support and community resources that are going to be available. They're going to have those safety nets there, because there could be entire neighborhoods that are, you know, just folks that are from the Dominican Republic or from Puerto Rico or from Mexico. Or Guatemala, and that has its benefits. But more and more we're seeing Latinos moving into non-traditional destination areas, and we're seeing populations in kind of places like North and South Dakota increasing exponentially in terms of the Latinos that are moving into those areas. And that has implications in terms of when we think about healthcare. You know, are there community resources that are available to them? Are there providers that are equipped to serve those communities? And those are going to be questions that are going to be really critical to ask moving forward, as our Latinos are not going just into these areas that they've traditionally moved into. Okay. So here's one that's pretty near and dear to my heart. Those of you that know me know that I have a lot of feelings about language and linguistically appropriate services. But in terms of the languages that we speak, there's a lot of variability among Latinos. And so while there are some that identify as Latino but only speak English, there is a much larger percentage of Latinos that speak some level of Spanish, and then with variable fluency in Spanish, but also variable fluency in English. We have other Latinos that they may speak Spanish, but especially when we talk about our indigenous communities that are coming up from Mexico and from Central American nations, they are also speaking languages, indigenous languages that are not readily available here in the United States, and that's definitely a factor that impacts the way that they navigate the healthcare system. But language is not something that we can ignore when it comes to how we interact with these communities, especially our Latinx communities that are not able to navigate the healthcare system in English as well as they could in their preferred language. So we'll talk a little bit more about that. Okay. So what does this all mean in terms of care? That's kind of the question that we're all interested in. I just shared with you a lot of different numbers. And I tried to preview as much as I could some of the challenges and the unique considerations that impact how Latinos access or experience care. The next slide will probably not be any surprise to anyone that's on this webinar. But in terms of, and to what Clarissa mentioned in her introduction, we see significant disparities when it comes to Latinos' physical health, but also their mental and behavioral health. Unfortunately, we see that Latinos, their utilization rates of behavioral health, and these are also the same for in terms of their accessing physical health care as well, but I'm focused more on behavioral health for the purposes of our discussion today. Their utilization rates are lower than non-Latinos. The quality of the care they receive is not where it should be. And in terms of their clinical outcomes, when it comes to behavioral health, we also see disparity there. So what are some things that contribute? Again, I don't feel like I'm telling you anything that you don't already know, but here are some of the sorts of things that have been identified as barriers and contributors to these health disparities, these behavioral health disparities. The cost of services, the lack of healthcare insurance those both are huge barriers to our Latino communities. Lack of transportation, kind of just a very basic thing. If you can't get there, you can't access it. And we see that being a significant barrier for some. The level of health literacy, fears around deportation and getting questions about citizenship, especially for our undocumented community, that can be a significant barrier, and we see that increasing kind of in terms of the current political climate. Cultural stigma in terms of, again, these beliefs and values that individuals might hold around what it means to access behavioral health services and what it means to admit or acknowledge that they're suffering. And kind of the big one in terms of, and I'm again biased, but in terms of a lack of culturally and linguistically appropriate services that Latinos can get access to. One thing that, a couple of things I wanted to highlight here, in terms of the utilization rates, what we see is that utilization rates are strongly linked to nativity status. So that means that our newly arrived foreign-born Latinos access even less services than our US-born Latinos. It also seems that, and not surprisingly, acculturation rates, or how much a Latino has acculturated to the US ways of doing things, also impacts utilization rates. One thing that is also important to keep in mind is, and maybe some of you have heard about this in the past, or this might be new to you, in terms of the immigrant paradox when it comes to health. And this applies to Latinos, it's been shown in Latinos as well, where newly arrived immigrants tend to report lower rates of illness, and that's true of both physical health and also mental health, as compared to Latinos that are born in the United States. However, as they start to acculturate the stressors of being an immigrant and part of the Latinx community in the United States, starts to build, and we see that kind of protective factor of being an immigrant in the United States start to diminish, and we start to see the stresses around acculturation, family stress as it relates to differential acculturation, all of those things build up, and then we start to see more of a spike in terms of both physical illness and also mental health related issues. Okay, so I say this to many people: if I don't have a slide on the class standards, I don't feel like I'm doing my job. For many of you that have done this work, you'll probably be aware and know about the class standards and be like, yeah, Florencia, we know. But for those that don't know about the class standards, I think it's important to put it on your radar. So the federal government is aware and has acknowledged, and there's been plenty of research that has demonstrated these health disparities as it relates to our minority populations, which Latinos are part of, and they're trying to at least do something to acknowledge the need to address these health disparities. So one of the many things that are being done is really outlining these guidelines for care and recognizing that we have an obligation to provide effective, equitable, understandable, and respectful healthcare and services to our communities, and that these services need to be both culturally and linguistically appropriate. And that's not something that our patients are responsible for doing. That's something that's on us as providers and as part of the healthcare system. So with all of that, let's jump into some questions. These are some that Clarissa had shared with me, and also touches on, thank you to those that also wrote in on the Google form. Hopefully some of these are starting to touch on those questions and topics as well. So one thing that comes up a lot in my discussions with folks about Latinos is, how much does it matter if we are being mindful of ethnic match? So does the ethnicity of the patient match the ethnicity of the provider? And a lot of people have, it's a great question. A lot of people have asked this question. There's been quite a decent amount of work on the topic. But in terms of what we know, the literature is really inconclusive. There'll be one study that says, yes, it matters. And then there'll be another study that says, no, it doesn't. And it's just back and forth and back and forth. And so again, as far as my read of the literature is that really, like, we either not particularly, or we just don't know yet. There's not enough data points to tell us one way or the other. So, there are implications if in fact ethnic match doesn't matter. What I've been impressed with is more those that have looked at this question. So what about language match? This is particularly important when we're talking about our Latino communities, because oftentimes what is the major barrier, especially for our limited English proficiency Latinos, is language. If they can't speak and communicate with their provider in their preferred language, then what chance is there to have good treatment engagement and good clinical outcomes? So some have looked at this, and there's actually been a sprinkling of studies that have actually looked at this in the context of integrated behavioral health, integrated primary care. And the literature does seem to suggest that language match does matter, and that even if you have a provider who is non-Latino but speaks Spanish, that provider has a better chance of having a positive impact on that patient than a monolingual English-speaking Latino. And so those are critical questions as we try to think about how to best meet the needs of our community. Those that have looked at it in the case of integrated primary care, you know, they've looked at kind of treatment. Yes, treatment engagement tends to be, we have BHPs that are utilizing interpreters. You tend to have good and comparable treatment engagement, but if it's up to the patient and you're asking the patient, what would you prefer? They're always going to prefer a bilingual BHP. And that, again, has implications in terms of, you know, I think a lot about workforce development, and that has significant implications in terms of how we choose to staff our clinics and our attention to training bilingual behavioral health providers. Okay, here's a question. I don't know how many of you struggle with this, but I do get this a lot, this question. In terms of evidence-based practices, and do they work for Latinos? And lots of people that are way smarter than me have looked at this and have studied it. And there actually have been some studies that have looked at evidence-based practices that are delivered in primary care. To see whether or not evidence-based practices work similarly for Latinos and non-Latinos. And the studies do seem to suggest, there does seem to be a good trend in the direction of that, that it doesn't, that evidence-based practices work equally well for our Latinos and our non-Latinos. But what tends to be the issue is treatment engagement. That getting Latinos to engage with the interventions is the problem. But once they do engage with them, they are effective. And so that starts to tell us a little bit about do we need to think about adapting our treatment engagement strategies in a way that are more culturally responsive? Because once we're able to deliver the intervention, kind of that active ingredient, it tends to bring with it good clinical outcomes. So what can we do in that engagement period to really sell the effectiveness of these treatments if our Latino patients meaningfully engage with them? Okay, so does PCBH or other integrated behavioral health models work for Latinos? There's not a heck of a lot of literature on this, but there is some, and I think it is growing because people are asking these really good questions. But the studies that do exist, some have looked at kind of a more PCBH sort of approach to integration. There is some studies that have looked specifically in kind of a more collaborative care approach to integration. And in both cases, it does appear that PCBH and other integrated behavioral health models do increase and improve our utilization rates among Latinos and our clinical outcomes. And there's a host of reasons why that is, but that's incredibly encouraging when we think about the lack of or the poor utilization rates and clinical outcomes we see in kind of specialty behavioral health. You know, the federal government also acknowledges that and has put a lot of resources into recognizing if we want to address the health disparities that exist among our minority communities, integrated primary care is going to be one of the ways that we accomplish that. And so it's really nice to see that the literature seems to be suggesting that that is in fact the case. So very encouraging trend there. And something again near and dear to my heart is, and this is also Clarissa raised this question, is in terms of what kind of specialized training is there for working with Latinx communities in integrated behavioral health. Here's kind of this is probably one of the most depressing parts of my job, is that when we think about, you know, okay, we've identified having bilingual providers is going to be critical in terms of meeting the needs of our Latinx communities. And we know that they need to not only be trained in how to be good and effective bilingual providers. But on top of that, we need to be encouraging them to go into integrated primary care sorts of settings, because that's when we're going to be able to really tackle those health disparities. I currently have some studies that are looking specifically at trying to make sense of what we have in terms of specialized training. And what I'm finding is that across the disciplines, we see a general lack of specialized training for bilingual providers, and then forget in terms of working on bilingual providers that are interested in going into integrated primary care sorts of settings. So there's a lot to be done there. We don't have any established guidelines for what the specialized training should look like. But I think that a lot of great, smart, intelligent people are starting to ask these questions, and I'm really encouraged by even groups like this that are shining a spotlight on the need for this, and that we'll start to see some momentum build in terms of addressing this lack of specialized training. One of the things that many have talked about in terms of what complicates trying to see like what would be a one-size-fits-all training for those that want to work with Latinx communities and want to be bilingual providers in the community. And that's kind of differences in terms of fluency level. And so one of the things we know when we look at workforce development, and especially when we're talking about Spanish language providers, is that we have kind of like three buckets that people tend to fit into. The first bucket is native speakers. And when we're talking about native speakers, these are providers that were raised oftentimes in a Spanish-speaking country, received their formal education in Spanish. Maybe they received their master's or doctorate level training in English, maybe here in the United States, but their formative education years were in Spanish. So they have an amazing command of Spanish, and that's their primary dominant language, and oftentimes English is their second language. So they're English language learners when it comes to English. So you can imagine that set of providers would have very different needs than the second group here, which many of us tend to fall into, which are heritage speakers. And so heritage speakers are oftentimes born, and they can be born into Spanish speaking households. Some of us, like myself, was born in a Spanish speaking country and then immigrated to the United States at a young age. But then received formal education in English. So many of our students, they'll say like, yeah, my first language was Spanish, but then the minute I got to kindergarten or first grade, everything after that was English, and I only spoke Spanish in the house. What we see is that they develop Spanish and English languages relatively simultaneously, but over time, English becomes their more dominant language because they're receiving their schooling in that. And what they'll report is they feel comfortable with conversational fluency, but then they like reading and writing and even their oral skills, and with professional language, they don't feel as confident. So you can imagine very different training needs there. And this is an area I tend to spend a lot of time in terms of trying to identify how do we build confidence in this group? How do we get them ready to be good bilingual providers, effective and confident providers? And then we have the last group, second language learners. So these are native English speakers that have chosen to learn Spanish as a second language. And again, they may have a command of kind of the cultural aspects of working with Latinos, but it's not going to be as firsthand like it is for our heritage and our native speakers. And so again, the levels of what they're going to need is very, very different. And so these are the questions we need to kind of address when we're thinking about training our bilingual providers to go into integrated primary care. And then in terms of kind of when should they receive this training? That's a big question. And, is this something where we try to tackle it in pre-service training years, their early career years, their advanced training years? Can we retrain folks later in mid and late career stages? Like that, those are all questions that we tackle in thinking about how to train a workforce to be equipped to meet the needs of Latinx patients. So one, this will be the final thing that I say, and then I'll shut up. But one thing that some asked about, kind of like resources and training resources in particular. I would encourage all of you to check out the webinar trainings, online trainings that you can receive through the Office of Minority Health. These are focused specifically on culturally and linguistically appropriate services and how we can deliver those. There's one for behavioral health providers, there's one for physicians, for nurses, all the different specialties are there. And there you can get continuing ed credits towards your license renewals. And I think they do a really nice job of tackling some of those big questions of like, how do we navigate, working with patients with such diverse backgrounds. So I encourage all of you to look into this because there's lots of nuggets. I've completed it and I took away so much from it that I really encourage all of you to look into that. And with that, I will be quiet and listen to all of your questions.
Thank you, Florencia, for that wonderful overview of these important factors related to working with our Latinx communities. I did want to start us off with one of the questions that had come through some of the Google forms, which, I think it's really interesting. I think it could potentially be related to this issue you brought up about engagement and the importance of therapeutic engagement in order to get to, the active ingredient, right, the evidence-based intervention. But, one of the first questions we got was about the fact that our BHC sessions, as you know, they are short, they're focused, they're targeted, they're brief, 20 to 25 minutes. And I guess there's a concern, how can these brief sessions address all the concerns in the moment? And so I think we all know that sometimes families come in or people come in and there's, when I talk to my students, I say it's kind of like a buffet of issues that you might be able to tackle with all sorts of CBT interventions. How do you choose what to tackle? I guess that's one issue, but I felt like maybe you could talk about it through the lens of this engagement piece.
Yeah.
I don't know. So I guess to wrap that up, let me ask, with a brief 20 to 25 minute BHC session, how does one manage all the concerns that come up in the moment?
Yeah. It's a great question. And so I should also say I tend to work more on the ped side of things, and so I will try to have my lifespan hat on and not just some pediatric examples. But I think one of the things, particularly when trying to get a request for a warm handoff, you're in a consultation and you're trying to engage, even maybe I think several of you talked about elderly Latinos. I have found that using that time, and I would say this is true of everyone, right? We're trying to identify like, what's the problem you're most interested in working on? What would bring you the most relief and make this worthwhile? We're all trying to kind of get that, hook them with that, right? And I think this is particularly important with Latinos. Many, we have this kind of stereotype of our Latinos, but this is also backed up with good data. In terms of they tend to lead with somatic sorts of complaints. So if we spend the whole you know, 25 minutes trying to convince them that their stomach pain is really anxiety, like we're not gonna get anywhere, you know. They're just gonna be like, nope, that's not what it is, right? And so
Right.
oftentimes when we're working with our Latino communities, it's you know, making sure that we're adopting for the time being their view of what the problem is. And if they're saying like, I have these, you know, horrible headaches, I'm having these horrible stomach pains, I don't know what it is, but I can't seem to get good enough sleep, and I'm just waking up tired, and I think there must be something wrong. Working within that view of the problem, and not wasting time trying to shift it to something that fits more into, you know, our more kind of like mainstream view of things. And I'm probably not telling you anything that you don't already know, but I find that is particularly critical with our Latinos. And then once we've got them engaged, you know, we're doing follow-up visits with them, that's when we can start to maybe ask good questions and explore how they understand their symptoms, and whether they're open to considering that it might be this other thing, you know, also, but not trying to do that initially when we're trying to engage them, just trying to get them to buy in initially. Right.
So it's kind of like meeting them where they are, right? And I love all that. I think it's a very important issue for, you know, all of us to keep in mind, especially even those of us, you know, have been practicing for a while, together with, you know, our new learners. It's a really key focus. Okay. I do have another question, which gets into a little bit of some of these cultural constructs related to the Latino population. And I thought this was an interesting question, and maybe we don't have a specific answer, but I think it would be a great discussion. And please, you know, if anybody has any thoughts or feelings about this topic as well, we invite you to chat with us through the chat boxes or the Q&A box. We would love to hear from you. The question is, how can BHCs better address Marianismo in the Latina women community? Especially for the first generation women over 55 years old. I want to be able to support these women, respecting their values and culture, but at the same time helping them set boundaries and to take care of themselves. So that's a huge question, and I think, but I love the question because I think it tackles the complexity that we are all faced with in these, you know, primary care visits. So I guess I maybe talk a little bit about Marianismo. You want to tackle that?
Oh, goodness. Yeah. So, I mean, I think one of the things is that when we think about these like very entrenched beliefs about, you know, what it means to be a Latina, what our roles are, what is expected of us as Latinas, and again, that's going to vary greatly depending on the country of origin in particular. I would say, where that's going to be a construct that's going to be more applicable, and then with other Latinos coming from different regions in Latin America, that's not going to be kind of the female lived experience. They're not necessarily going to come with those tightly held beliefs or kind of cultural expectations of what they're able to do or not able to do, or how they should be conducting themselves or not. And so I think the first piece is like all of these kind of constructs is making sure that you're exploring with your patient if it's something that really fits, like making sure that you're never assuming, and that you are giving space to talking about kind of like how do you see your role, you know, in your community, how do you see your role in your family, like help me understand. And again, the brevity of sessions is an issue, but that's that's not to say you can't. This is something that you can do in that context, and it's going to be pretty critical in terms of moving forward with those patients. I think the other thing that I have found is that here in San Diego, we have a large, obviously, Mexican and Mexican American community, and I've also found that as, you know, a Latina from Argentina, I have a very, very different kind of lived experience, and I always have to be mindful of that. You know, we're also setting, you know, realistic expectations of what our patients, you know, how far we can push them and how quickly we can push them, and then recognizing that there might be things that are going to be entrenched and might not be something that we can adjust in the context of our work together. But, you know, finding opportunities to appropriately, you know, challenge or be curious about, I think we can do. But it's a really tough question. And it's something I tried to look, if somebody had written some amazing conceptual paper, or somebody had said, I haven't been able to find anything. So these are also really wonderful questions to explore, and some good qualitative research on this would be excellent for those of you that are interested.
Absolutely. No, and I agree. I mean, I think it's something to really delve into, and it's you know, it's a great research topic for all you students out there to kind of think about this together. I love this idea, like, be careful. I mean, it's kind of what I hear you saying. Like, we must be careful and tread lightly so that we don't use a lot of our own lived experience. You know, I come from a family where this was very much the predominating flavor of the women in my family. So I have to be careful, right? That's to project all that onto the people I work with. We do have another question coming through on the chat box. What's your perspective on using interpreters during behavioral health visits? Could they be seen as cultural brokers when the behavioral health professional is non-Latino or non-Latina?
Oh, this is I love this question. I hope it's not somebody who knows me and knows that this is like a hot button topic with me that I could spend 100 hours talking about.
No.
Oh, good. So good. You know, interpreters, in a perfect world, we would have providers that speak every language under the sun, and a patient would be able to come in and say, I need to see a provider that speaks this language. That's my preferred language. Please have that happen. And it's not going to. And however quickly we all work to try to get more Spanish language providers into clinics, like, we're never going to be able to move fast enough. And there's never going to be enough of us to meet that need. So that's why, you know, our other focus has to be on training monolingual English-speaking providers to provide culturally appropriate care, and to appropriately use interpreters. I still have some monolingual English providers that have really interesting, you know, will talk to me about very interesting beliefs about the use of interpreters, how they should do it. And there's a lot of work that needs to be done in terms of educating folks on how to use them. My opinion on being able to use them as cultural brokers, I think there are good ways of doing that. So for instance, you know, best practices when working with an interpreter is that you do if possible, you're doing like a pre-brief with them, like kind of prepping them on who they're going to be seeing with you. And then also speaking with them after, so doing like a debrief at the end. And I find like those are the moments to, if you have questions as a monolingual English provider, or, you know, Spanish language provider, you know, working with somebody who speaks, you know, Farsi. Those are the times to ask, you know, if I say it this way, you know, would you be able to interpret other words that you know, and concepts that line up with what I'm trying to get across to this patient? Or at the debrief, like, is there anything that you noticed in their word choice that is telling that I should know about, or, you know, about their affect, that would be kind of more of a cultural dimension that you can share with me. So I think, of course, you can use them. in those ways, not in the encounter itself, but making sure that you're utilizing them pre and post, I think is, as cultural brokers, I think is excellent. If you have the time to do it, do it.
Wonderful, thank you. And what a great, like, what an added, I mean, I think it highlights like the added dimensionality that occurs when, you know, working with this population, this kind of debrief at the interpreter. We have another question. How do you appropriately ask about citizenship or documentation status or migration journey so that you have that context but don't want to make the patient feel uncomfortable or unsafe?
What a good question.
What a beautiful question.
Yeah, and what an important question.
Yeah.
My experience, and I'm sure that somebody has probably written something really eloquent about this, and I haven't located it. So I'll just kind of speak from my experience. I find that for me, again, as an immigrant myself, as a Spanish speaker, I tend to use also, oftentimes I'm working with not people that are from Argentina, but from other Latin American countries. And so I tend to introduce kind of the immigrant kind of question early, but by putting it on myself first. When I speak in Spanish, I obviously speak with an Argentinian accent. And patients love to try and guess where I'm from, and I encourage them to do it. And then they'll ask me, about my own immigration story. And when did you come here? And like, do you go back a lot? And so then I share that with them, and then it makes it a little bit easier for me to then ask them questions about how they found their way here. I think it's critical at this time, and especially with all the things going on recently in regards to ICE and the use of mental health progress notes. I think it's critical to review issues related to confidentiality, what you need to write down and what you don't. I tend to not be a note writer in session, and I think that also helps. Like if somebody's telling you, I'm undocumented, or my family member is undocumented, and then you're sitting there writing it down, that's not going to necessarily make people feel comfortable. So put that down. And make sure that you are being really explicit about, what you need to share with others and what's just between the two of you. So that's what I have found to be helpful, but I'm sure lots of people have great ideas about how to approach that. It's such a delicate topic.
It is. I think it is so delicate, and I think it's, at least for me, and I'm thinking about Norma too, like this is something for our group to really further explore, right, as time goes on, and maybe we can have an answer or better, perspective on this at our conference. There's another question kind of related to what we were just talking about that actually ties into one of the questions that came in from the Google form. So, you want to ask about this immigration status and journey, but what if you are of the majority population and you need to ask this question? And that kind of ties into another question about that came in through the Google Forms, which is how do you discuss or bring up race and ethnicity in this really quick 25-minute PCBH session without offending the person or, building distance rather than building, engagement or closeness?
Yeah.
So, again, huge issues, I know, but I'd love your perspective if you've got an opinion.
Yeah, I think the question about a monolingual or a majority, somebody who identifies as part of the majority and then having to ask those questions. I think in that case, if you obviously can't rely on your own lived experience to just try to kind of make things more familiar. I think it's going to be more critical to just be, really, really clear about issues of confidentiality and privacy, because I think that's the biggest fear, is that you're going to notify somebody, or there's going to be something that's documented that will find its way into the hands of authorities that may or may not act on it. So I think that's going to be a critical step. I wish I had more suggestions on that. It's a really great question. And when I agree, Teresa, would be wonderful to explore further. In terms of how to explore, I would really encourage you that those webinars that the Office of Minority Health put together, they have lots of great resources and suggestions on how to explore cultural identity without relying on overgeneralizations. I definitely, in my own clinical practice, I know the pressures of needing to get in and get out. But I think part of providing culturally appropriate care is recognizing, if our goal is meaningful treatment engagement and good clinical outcomes, part of our adaptation needs to be like, maybe we're going to have a couple extra sessions than we normally would with maybe a non-Latino patient, to really make sure that they feel understood and seen and heard. I've definitely experienced that for myself. If I have to spend a session like doing that, then that's what I'm going to do, because my goal is to make sure that parent is going to bring their kid back. And if I just kind of gloss over stuff and they don't feel like I'm really trying to understand their family and their customs and their traditions, they're not going to trust me to continue working with their child. So I think that's when we have to start thinking a little bit more outside of the kind of the typical box, and allowing ourselves to make those decisions, those clinical decisions.
No, absolutely. And, I guess part of what I'll say when I'm trying to, the word delicate has come up so much. I think it is a delicate issue. The relationship and engagement has to be dealt with in that way, delicately. And so I often try myself, when I'm engaging a family where it feels very delicate and I need to get this information, I really rely a lot on my nonverbals. I will try to, be as respectful as possible. Oftentimes, I try to put my hand over my heart as I'm asking a very important question. I will try to, even like sit down or below the eye gaze of another person so that they understand that I want them to feel in control and that they have some power. I'm not walking in with a power stance. And these are very kind of minor things, but we know from brain and the research on neurobiology that these nonverbals are sometimes stronger, right? Yeah. And a better way of communicating things than our actual words. And so I really rely on that as a way of trying to establish and engage families where, and again, I don't know there's probably no paper written on this, but it's a strategy for sure that I use.
No, those are beautiful suggestions. Yeah, and I think it's for many of our patients, they don't, anything you can do to make them feel like they have agency, anything that you can do to make them feel heard and they're not being rushed and you're not multitasking, but you're really kind of there with them and really want to hear from them, that's going to go a long way. The fact that you're being curious is going to go a long way. And sometimes in our integrated primary care clinics, like the mentality is like, we gotta keep going, we gotta get more, but it's about slowing down a bit when we need to, and no, we might just need to take a little more time.
That's right. Oh my goodness. Well, thank you so much, Florencia. We have about 2 minutes left and I have a couple of announcements.
Oh, excellent.
So I am going to wrap up this discussion. I think this is a very fruitful discussion and obviously something very important. I definitely think and hope that maybe these are issues we can tackle going forward. I'm so excited that we have this forum to just bring all these issues to the surface. So thank you so much, Florencia, for that wonderful discussion and for answering all these questions and providing your expert opinion on all these issues.
Not my expert opinion, just my opinion.
I love it. I love it. You're so sweet. Well, I consider you an expert. So, like I was telling her, it's great to have the academic piece to my community-based work. So, okay, our next primary care behavioral health phone call for all members and for anybody interested in learning more is on April 22nd. We've got some time. We have a lot of good information and we have a lot of things that are happening. If you're interested in being involved, please let us know. Our next webinar will be in May, so please keep looking at the website and we will keep you up to date about our next webinar coming up. Thank you everyone for attending. Thank you, Florencia. Thank you, Liana. And everybody have a great afternoon. Thank you.
Thank you, everyone.